Okay. So I hope everyone is well caffeinated and ready for this next session. I'm very excited about this session. Nutrition has been a real big interest of mine for a very long time. It's a complex one in humanitarian settings, and this is a first panel on this at any of our symposia, and so we're really grateful. Shelley, thank you for leading this effort. Shelley Walton, she's a senior research associate at Hopkins Bloomberg School of Public Health with more than 15 years of experience in humanitarian and development settings, focusing on improving nutrition and health outcomes for crisis-affected populations through research and implementation science. So Shelley, I'll let you take it away to introduce your team.
Can you all hear me? Oh, perfect. Thank you. I'll let everybody trickle in from coffee here. Thank you so much for the opportunity to Ayada and Sylvia and Philippa and Anna. I think we maybe met 2+ years ago where we were connected and started talking about the possibilities of something related to nutrition and food security for people living with diabetes. So I'm really excited to be here today, sitting and moderating this panel. I think the other thing to mention, because we're talking about people with lived experiences, is that I'm a mother of a child with living with diabetes too, so have been able to appreciate all of the conversations with that hat on as well. So let me start by introducing our panel. And do we have Omar on? He's online. Okay, great. So first, let me introduce Mesa Halini. She's a clinical dietitian and nutrition specialist working with MSF. She's been working as a dietitian since 2021. She focuses on really raising awareness about healthy eating for individuals and families living with diabetes through personalized plans. And we're very excited to hear your experience in Lebanon, and welcome. We have Omar Haji online. Hi, Omar. Unfortunately, Omar wasn't able to.
Hi.
Hi.
Thank you so much. Yeah, it's you. Okay, thank you.
Great to see you. So
You too.
Omar Haji serves as the Deputy Health and Nutrition Coordinator for the International Rescue Committee in Somalia. He has over 13 years of progressive experience and has led the design, implementation, and management of health and nutrition programs. And welcome, Omar. Thank you so much for being here with us. Next on the panel, we have Dr. Lamis Yoma, who is a teaching assistant professor in the Department of Nutrition at the Gilling School of Global Public Health at the University of North Carolina, Chapel Hill. She serves as an adjunct professor at the American University of Beirut as well, and has research experience of over 15 years really focusing on food and nutrition security. So thank you for being here. And then last, but certainly not least, we have Caroline Wilkinson, who is a public health and emergency nutritionist with over 30 years of experience working and supporting humanitarian nutrition programs across Africa, Asia, and Europe. She's worked with numerous organizations really across the world, and we're so happy that you can join us here today. So thank you. All right, so if we can get back to the slides. Perfect. So what are our objectives, or what do we hope to do by the end of the session? We really want to be able to map the nutrition-related challenges faced by people living with diabetes in humanitarian contexts. We want to really take some time to highlight operational realities, research experience, and lived experience through field case studies, and we have 2 that we'll highlight here today. We'll focus on bridging the research policy and practice gaps, identify opportunities across humanitarian food assistance, diabetes care, and nutrition support. And then lastly, we really want to spend some time on some dialogue and really think about a way forward a forward-looking agenda to address some research priorities, which we fortunately started doing already this morning, focus on some policy gaps, and then really have it grounded in operational opportunities. So what can you expect? I'm going to kind of set the scene with some background. We'll dive into some case studies, then we'll talk about evidence and research priorities, policy and action, and then we have a lively discussion. That all of the discussions have been very lively, so I anticipate that this one will be as well. So let me start by setting the scene a little bit, and I've been asked to define some terms for the group here. So some of you are familiar with some of the terms, some might not be as much, so just bear with us for a few minutes as we kind of lay the groundwork here. So first is food security. So food security is a situation that exists when all people at all times have physical, social, and economic access in sufficient, safe, and nutritious foods that meet their dietary needs and food preferences. And I think what's so critical about this definition is that we explicitly need to recognize all the dimensions here. And then food assistance. What is food assistance? It's required when the quality and quantity of food available or access to food is not sufficient to prevent excessive mortality, morbidity, or malnutrition. And there's a wide range of tools that we can consider as we think about food assistance, and we'll kind of unpack those more here today. Nutrition. What is nutrition? Well, it's a broad term that refers to the process involving eating, digestion, and utilization of food for growth and development, reproduction, physical activity, and maintenance of health. And the term malnutrition, this includes both undernutrition and overnutrition. I will say that typically in emergencies and humanitarian contexts, the primary focus is on acute malnutrition. So we think about prevention and treatment of wasting often. We don't spend as much time thinking about chronic malnutrition and what that might look like in an emergency response. And then certainly to date, overnutrition has not been prioritized. We also think about targeting certain vulnerable populations with nutrition interventions in these settings. Typically, these are children aged 6 to 59 months, older people, people with disabilities, people living with HIV, and pregnant or breastfeeding women. The thing that I'll say, and we looked across multiple different guidance documents and policies, is that people living with diabetes is not noted as a vulnerable group to target, nor are people living more broadly with NCDs acknowledged and included in a lot of the nutrition targeting and humanitarian assistance. So why even talk about nutrition and food security in this setting? What is the value and what is the importance here? Well, we know that the nutrition crisis is in fact worsening and intensifying, and it's most severe in complex humanitarian emergencies. So to date, the latest statistics that we have is that more than 294 million people across 53 countries are in some state of acute food insecurity. So just think about that number. It's tremendous. It's a tremendous burden. And we know that conflict, economic shocks, weather extremes, and structural fragilities continue to drive the food crisis. The four most severe crises are in Gaza, Sudan, Yemen, and South Sudan. And we know that about 80% of refugees and displaced populations experience food insecurity. So all of this is terrible and really devastating to deal with to begin with. But we know now, too, that the substantial funding reductions in early 2025 have put at risk a lot of these life-saving nutrition interventions. So the situation is just getting worse and intensifying. So then you might ask, well, where's the greatest burden? So we can see in the map here, we've highlighted the darker the color, the worse the food insecurity situation. And not surprisingly, we're seeing that across sub-Saharan Africa and some parts of the Middle East. And what I love is then kind of comparing this to where we expect diabetes to increase the most in the next 25 years. So the same countries and regions with the greatest food insecurity are also the ones expected to have the greatest increase of diabetes from 2024 to 2050. So again, experiencing in Africa and MENA. So this then leads us to a really wicked problem, right? We have extreme food insecurity and nutrition vulnerabilities in settings occurring alongside this growing number of people living with diabetes. And why does this matter? Why is nutrition and food security so important for people living with diabetes in humanitarian settings? And we can unpack it in several different ways, but if we think about type 1 diabetes, for example, food is really used as a safety device, right? So insulin without food can lead to hypoglycemia. Food without insulin can lead to DKA. We need some predictability with regular meal timing, enough carbohydrates and protein. It's really life-saving in these settings. We also need to think about adequate macro and micronutrients being so essential and critical for this population as well. With type 2 diabetes, we really need to have food access, diet quality, and some routine to ensure glycemic control. And in humanitarian settings, the rations that are given typically would consist of low-cost foods that are accessible and are typically consisting of sodium. They're rich in carbohydrates, low in fiber and whole grain, and typically don't have many fresh fruits and vegetables. Again, in this population, we would want to make sure that there's adequate macro and micronutrients. So again, essential to have good nutrition and food access. Gestational diabetes, we talked a good bit about yesterday, which I really appreciated. But as we know, irregular access and quality to food can lead to poor glycemic control and then can lead to really big impacts for the mother and the child in terms of health outcomes. And during pregnancy, the nutritional needs increase and change. So for example, more calories are needed. Iron and folic acid is essential. So is calcium and iodine and other micronutrients. And then I think that I can't not have a slide like this without talking about diabetes prevention as well. So we know that malnutrition during these important stages of growth early in life, if malnutrition exists, if diet quality is poor, we know that this leads to increased risk of type 2 diabetes later in life. So again, essential throughout. And then just the last couple points here, what are some of the common approaches that we might expect to use in emergency nutrition programs? And just to unpack this, because we're going to discuss it more later in the session. So one of the typical types of food assistance that's provided is what we call a food basket. And a general ration is typically distributed in emergencies to deal with nutrition and food insecurity. A typical food basket might include wheat flour or rice, lentils, vegetable oil, sugar, and iodized salt. So we can see that it's typically high in starch, oil, and sugar with minimal fruits and vegetables. It's really designed for an acute emergency stage, and that is the main goal. Philippa has very generously put together what a daily individual ration might look like. So we have the rice example displayed up here for you. So this is an individual ration that you might consider seeing or that you would commonly see in a humanitarian setting that would be considered kind of the food basket. It is not distributed and delivered in these nice neat displays. It's typically distributed more in bulk. So imagine that an individual or household might be receiving a monthly ration, and it would be like a bulk bag of rice, for example. So again, very minimal in terms of the dietary diversity here. And then the last point that I'll make, because again, we'll be talking more about this, is cash and voucher assistance. So this is another approach that we can consider when we're considering food assistance and nutrition for people living in humanitarian settings. And it is becoming more common across sectors. And what the defining characteristics is really that it is a transfer either it can be done mobily or through a bank transfer, and it's cash that's defined to be used for food purchases or other household purchases. One of the key things about this is that it can promote dietary diversity. It gives a lot of ownership to the individual or the household to make their own food choices, but it's very restricted based on the availability of food in the market and the overall functionality of the market. So these are just a couple definitions to start us off here. And with that, now that you all have all the definitions and the framing, we're going to get into our case studies. And we will start with Mesa.
Hello, my name is Maisa. I am a registered dietitian working with MSF in Lebanon Mission. I want to thank Ayada for the invitation, and special thanks to MSF, Dr. Philippa Boul, for giving me this opportunity to taking part in such an inspiring event. I'm here today to share some insights and experience from the mission, but first I want to introduce MSF in Lebanon Mission. It's responding to Syrian refugees and Lebanese population since 2010 with PHC activity levels, including NCD care, pediatrics, SRH. We have almost about 1,070 DM2 patients and 148 DM1 patient distributed in 2 clinics in Bekaa project. The care provided by many people, nurses, doctors, pharmacists, but this project is the one and the only project who has a nutritionist consulting patients, mainly DM1 patients, and giving like personalized plans, meal plans for them. I want to start with a general context. I believe, as we all know, that diabetes is linked to many factors, including diet, medication, physical activity, stress, and many other factors. It requires a good balance between those factors. But in emergencies and during crisis, I believe that this balance is broken and food security becomes weak. So people may face many challenges regarding the access to food, the access to insulin, the access to store insulin, the electricity. So it will be very hard and difficult to deal. I have seen many patients that just skip meals because the food is limited. So this may be risky and cause many side effects, including the hypoglycemic episodes. Another point to share is the food choices. What are the advices for the patients how to choose food? I believe that it is not to choose an ideal option or the perfect option, it's to choose what is available. We can advise patients, especially as Shelly mentioned, for the food basket, if we have like white bread, is to pair it with other kind of food groups like vegetables, proteins, fibers, fats. It's just to slow down the sugar absorption. And if you have like fruits, it's better to eat whole fruits instead of drinking like syrups or juices. I had one patient during the last tour in Lebanon in September 2024. who just had rice to eat, no other food. So the advice was to divide the available amount throughout the day instead of eating the full amount in the same meal. So it's all about portion control and regular meal timing and dividing the available amount. Also, during the last war in Lebanon, I believe in community support. We created a WhatsApp group because not all people were able to reach the PHC center to get the insulin and the medication, so we're sending one focal point. So this group was to share educational content, interactive questions, nutrition practices and practical tips as well. Patients were actively engaging and sharing their daily challenges and responding to polls, to quizzes. So it became like a learning space and a community support rather than just a WhatsApp group. They would connect between each other and motivate each other, and this group is still active till now, so we can communicate and collaborate. So what we can do practically, I have some practical solutions and recommendations for the community support to reduce the stigma. First of all, the main important point is to avoid distressing the behavior of the patient. We have to try and to understand this behavior and to try to change into a good one. I had two patients after war. One patient who was just injecting extra insulins, but just because he wants to eat more sugars. And the other patient who was drinking a lot of energy drinks like XXL. So we tried to understand this behavior and to put like a short-term goals to reduce gradually this behavior than to stop. Also, I have a practical solution to provide regular and nutrition recommendations for patients, for people living with diabetes, to teach them the easiest way and the healthiest way to be followed, not the perfect way. I can mention a method regarding this approach is the carb counting method and the easy portion sizes. I can show you the easiest methods. This is the easy portion sizes that people living with diabetes can follow in crisis and in emergencies. And the other one is the carb counting method. It's in Arabic. I have another version in English. So it's the easiest way to help patients like follow a good healthy lifestyle. I can show you some pictures about the peer support group as well. It's a community support and learning space for the patients. Another practical recommendation is to collaborate with other healthcare providers for medical and nutritional recommendations, as well as giving some guidance during Ramadan fasting, because they fast for a long time of hours, especially during crisis. It's important to teach them the easiest way. And some recommendations for organizations, of course, to add some friendly diabetic food like whole grains, oats, some kind of fresh vegetables, and to advise patients also to pair it or to combine it, the refined carbs with other food groups, to train the medical staff in the organizations to be more go into deep nutrition questions, and of course to strengthen and expand the nutrition knowledge of medical teams. Finally, I want to share my experience in carb counting. It's an approach that allowed me to control the diabetes of the patients. We started gradually into basic counting, then we turned it into advanced carb counting. I kept a close contact with the patients to guiding and calculating their food accurately. So after doctor's approval, we implement the carb counting diet for many patients. So So they just adjust the insulin based on what they are eating. So it's a good approach. But in emergency, this can be possible, but not perfect because patients may feel not comfortable or stressful to follow this way. Finally, I believe that nutrition is not a luxury. It's an important part of treatment. Few adjustments or small actions can make a big difference. And thank you.
Thank you so much for those examples. Maybe we can hand around, if you don't mind us passing around the sheets that you brought too. That way folks can get a closer look. So thank you. All right, so Omar, over to you.
Yeah, okay. Thank you so much. And thank you, Triad, actually, for giving us this opportunity. I'm happy to uh, represent IRC, and I'm delighted actually to present on the preliminary finding from IRC formative work, actually, with the title of Developing and Testing Strategies to Improve access to and consumption of health foods for Somalis living with diabetes and hypertension. Uh, in generally, IRC has been actually working in Somalia for a long time, and we have been actually integrating the NCD with the primary health care and the community engagement with community health workers. Actually, we have been working with curriculum development and training materials for the CHW, but in generally, I will be actually giving a brief on the finding from our formative work. Still, we are conducting the research, and maybe the next year we will be able to provide about the implementation outcome and all the steps. But can you go to the next slide? Yeah. So Somalia is currently actually facing for uh, um, overlapping crises, mainly conflict, displacement, and recurrent droughts. And I think I actually have mentioned that also. The primary focus currently is mostly on the nutrition program, with the focus of acute malnutrition in health system, primarily like Somalia is also focusing on infectious and acute malnutrition rather than the NCD. So there is a rising actually burden of non-communicable disease in Somalia, including diabetes and hypertension, and this actually needs to have a new approach is to actually tackle. There is also absence of national guidelines for supporting people with diabetes and hypertension, particularly regarding their nutritional needs, the food assistance even, and I think this is have been covered in the slides earlier, that the food assistance is often also high in refined carbohydrates and low in protective nutrient. And I think this is the background that we have actually under rationalization of this study. Can you proceed next step? Next slide, sorry. So the main objective was to understand the dietary practices, the barriers and the coping mechanism, uh, also to understand the service delivery, the perception of healthy eating and health seeking behavior, to identify the policy governance and system gaps actually was part of the study, and also to inform culturally appropriate nutrition and lifestyle strategies. Next slide. The study approach or methodology, mainly we did um, it was conducted in Mogadishu in Somalia, and mainly was targeting people with or individuals with diabetes and hypertension, and also to find out how they are managing the health food options and to uncover related system and policy challenges. So we did stakeholder workshops and design workshops with mainly with the Minister of Health, WHO, NGOs, and community leaders, uh, actually to discuss the barriers, the opportunities, and also to co-develop the study tools. And also we conducted an interview with the key informative interview, mainly involved in the policymakers, the clinician, the nutrition managers, to assess the gaps in service and the NCD programming. We did also focus group discussion that we held separately with men and women living with diabetes and hypertension, also to capture the personal experience, the dietary choices, and the coping strategies actually. We did market and food environmental assessment, also to evaluate the cost, the availability, the accessibility of food suitable for diabetes and hypertensive patients, highlighting local price and supply issue. We did the data analysis, next slide also. So I would like just to actually share briefly on what we have, the feedback from the key informative interview. Regarding for the role of the stakeholders, for the key informative interview, it was actually for 9 areas. What was the role of the stakeholders? And mainly we found that limited engagement in nutrition policy, advocacy, and resource mobilization. While they actually more involved in capacity building, in policy integration and the community awareness and health system strengthening generally. Regarding for the perspective on dietary messaging, the key informative interview actually indicated that the dietary challenges that include of high fat, sugar, and salt intake with generic advice, if at the clinic and the hospital is, so there is need to for practical, avoidable, and cultural tailored guidance using visual community channels and promote health Somali traditional foods. That was actually regarding for the perspective on diet messaging. That is what has been advised by the different key informative interview. Regarding for gender responsive messaging, we found that men lead the decisions while women need empowerment and resources actually. Therefore, if we need to improve actually the dietary adherence and equity, we should need to have actually encourage that women to be empowered actually in decision making and framing the nutrition as a shared family responsibility. For the physical activity and exercise, the key informative interview actually indicated that sedentary lifestyle with barriers like safety, stigma, and limited facilities specifically for women, and specifically this assessment or this study we did in Mogadishu, the capital, where there is maybe could have some challenging security and safety and something like that. Next slide. Then regarding for the leadership, governance, and financing challenges, the key informative interview indicated that there is a weak NCD data, fragmented policies, and no dedicated funding. The priorities being mentioned included that there is NCD budget lines to be actually established, integrate into the national plans. An MOH actually is being considered as a pivotal for coordination and partnership for the surveillance. There is need actually to have the DHIS to be included actually the NCD indicators like screening, diagnosis, and follow-up, and capacity building with actually need to have the real-time dashboard and digital harmonization. Regarding for dietary evidence gaps, there was feedback from the key informative interview that there is a need for cultural tailored intervention, and also barriers they indicated include that the cost, the seasonality, and the supply chain. Next slide. For the policies and partnership and community initiative, there is weak integration of the NCD into the nutrition and the food policies, and this is something has been existing in Somalia. And that is why they recommended the need to have a multi-sectoral cooperation from the health, from the agriculture and food. For the food system strengthening, there was a recommendation to support local production and improve market access. Research priorities being indicated was included in the implementation study, rural via IDBs population, and dietary behavior and service access. That is the key research priorities that's been indicated. For cross-cutting recommendation from the key informative interview that there is a need to develop Somali-specific diabetes and hypertension guideline, and also ensure that patient-centered, culturally appropriate intervention, and also to strengthen the government ownership, the woman empowerment, the health literacy, and the community leadership. Next slide. And then if you look for these key informative interviews from the focus group discussion, it was mainly focusing on 4 thematic areas. One was the service delivery and the quality advice. Most of the participants from the focus group discussion, they indicated that they received continuous counseling. However, they indicated that about the costs related for accessing for healthy food is and also limited finances. Actually, that is what they indicated. For the food environment, they mentioned it that the health food exists, but also largely unaffordable, and because of the economic constraints, like reliance on that has led or people they usually rely on cheaper established like rice. In addition, that they mentioned the drought, the floods, the unemployment worsened the food insecurity in Somalia in generally. Thematic number 3, it was mainly focusing on social norms and cultural beliefs. Actually, they indicated that household norms and gender rules shape the dietary practices, and also maintaining separate diets is challenging with the economic constraints that we have indicated. And also, they mentioned that the hospitality culture makes sometimes reviews and sharing meals difficult. Religious beliefs coexist. Some of the key informative, they mentioned that illness is from Allah and something like that. So I think was part of the key finding from the socioeconomic and cultural beliefs. Next slide. This slide also covers thematic area number 4, which is mainly the policy and the governance. So currently, the government support for NCD patient is limited, and therefore, most of the health facilities, the public health facilities, they depend on the NGOs and donors for specifically when you look for the medicines and basic care. So therefore, participants, they indicated that the need to have actually support for local agriculture and also financial and food assistance, home monitoring devices, specifically for people with hypertension and diabetes, and also supply chain strengthening and policy integration. So in generally, while we can find that people have high individual motivation, but also there is a systemic barriers like economic, social, and policy. And therefore, this actually is making it challenging for people living with diabetes and hypertension. We believe that programmatic and policy implications could include that integrating dietary counseling into the primary care. And I think this is something we are currently working as an IRC, and also provide subsidize and for local health foods, strengthening community health education to shift to norms, support local agriculture for NCD sensitive foods, and include NCD national and nutrition reliance policies. Next slide. So this slide is just mainly covering on the recommendation that there is a need to develop Somalia-specific NCD nutrition guidelines. Specifically, that can focus on diabetes and hypertension, as considering that diabetes and hypertension is the leading NCD in Somalia. When we look on the data, and also expand the community NCD screening, also enhance the training for MCH and primary healthcare providers on diet counseling. I think this is also something missing currently. Promote local health foods market through agricultural support, establish multi-sectoral coordination. Limitation from the study is that we conducted only in Mogadishu, the capital, where there is an IDBs and host communities, and it is an urban. Therefore, the qualitative design also, the methodology, and also the small sample, but the strength actually that it contain actually rich contextual insights and gender balance and focus group discussion policy relevant data that can be considered as a strengthen. As a next step, co-design intervention pilot with the community and Ministry of Health, and also test simplified dietary counseling tools, and also advocate for NCD sensitive action in national policies. For IRC, currently we are working actually to, we are at the final stage of testing the simplified dietary counseling tool, which we have developed, and still is actually to be validated in the coming weeks. And also we are working actually with to also deploy on cash assistance with NCD patients, also as part of the study. So thank you. Thank you so much.
Thank you, Omar. That's wonderful. I think that this is a perfect example of some formative work and a research that can be done to really integrate and think more deeply about nutrition and food security for people living with diabetes. So we will, oh yes, thank you for reminding me. Omar's team actually was able to record a video for us, so we're going to go to that next. Perfect, thank you.
cudurkan waxaan la noolahay 19 sano waxaana ka qaaday dhibaato ka timiday xagga dagaalada kadib markaan barakacnay oo u baxnay dhinacan Shabeellaha Hoose ayaan waxaan la kulanay dagaalo iyo weeraro iyo dilal badan dad kula socdo dad adiga ehelkaada la dilay waa fikirnay problemka dhiig karka qaasatan waxaan ka qaaday mataqaanaa iyo sokortaba يعني بروبلين يجي من حاجة معناها الدجالة السكية ومانته دجالك ودنك كسر أما ضد بدنا نقص ويرانو أما جودها أنا قلفت إنه عن إسلامه قال ضد بدنا نقانا أو عدو كان النور عدنا يعني عدو كواجرا وكجرا لكن مسك مارين كران داوم يبسن كران مهلي كران راشين كي مهلي كران أو معناها لو قلت لقى قويسكي إنه وحي يالها عنايان إنه عنان وكو قصبين بريسكي باستدي وكره وحياله aan loo baahnayn inay cunaan ana duruufta ayaa kalifayso duruufta kalifayso inay mataqaana raashin gooni oo yar oo special ayaga ay sameystaan waxaa jira mataqaana dhaqaatiirta markaan u tagno waxayna leeyihiin mataqaana waxyaalo daawooyin waxayna siiyaan waxayna noo sheegaan yani diet-ka qaata raashinka ay raashin hebel waa soo kicina dhibaato u keena raashin hebelna waa mataqaana ma karayna marka hay'adaha iyo dawladda Soomaaliya iyo cid allaah dadka dibadaha jira waxaan ka codsanaynaa inay naga saacidaan ama naga kaalmeeyaan dadka halis ugu jiro cudurradan dhiig karka iyo mataqaanaa sokorta inay nagala kaalmeeyaan rajaynayaa oon ka codsanayaa.
Great, thank you. So I think the video really gives us a, real life example of what it looks like and some of the challenges related to nutrition and food security in Somalia. So Omar, thank you so much for preparing that. So next we'll move on to Lamis to talk about research priorities and gaps.
Thank you. Thank you first to Ayada, thank you Shelley, and for all my colleagues. And it's gonna make my life really easier because a lot of my beginning slides have been covered. But I do wanna say I'm also a nutritionist. So if people wanna stretch, stand, I'm gonna be the first person. I feel like it actually cognitively helps. Feel free to stretch out. I won't take it personal if people don't, but if you do wanna, feel free to do that. It also will help me transition and get into the next slides.
You're gonna lead us in a dance?
Would love that, but not my specialty. And feel free to, join in the way you feel comfortable. I truly appreciate Omar's example of the formative work. Like Shelley was saying, this really anchors what we're going to talk about, but also the examples of registered dietitians, Maysa, and her work in Lebanon. I think both really give us a good example of what are some of the challenges, but also opportunities. We're going to build on that. We also had a really healthy discussion this morning, so let's dive in. I think we all agree in the last day and a half to talk about this, and many of you are actively working on this with patients directly or living with the diabetes of all different forms. Crisis-affected populations with diabetes do face those great constraints. And limited access to food, be it in quality or quantity, are definitely some of the key issues. This is why we're really appreciative of bringing the conversation on food security and nutrition as part of what IADA is also promoting moving forward. Also, we have challenges with access and care, mainly with high medical costs. Keep that in mind, because that definitely adds more to the stresses, which also, in collaboration or in association with food insecurity, makes things even harder for patients and people living with diabetes and their families. During crisis and humanitarian settings, nothing is normal. We've lived it. I have lived experience with that. I'm originally from Lebanon, from the south of Lebanon, so I know what a disruption of a system is, and I've lived it over many years. Every time I talk about it, it hits home, because it is not something that is abstract. You do have a destruction of the food chain, the supply chain. You have a destruction of the places where you trust to go and get your market and groceries. It's the disruption of the health system where you can get your access and support. You lose people, like our colleagues in Gaza were saying, 21 plus people who actually were lost. So this is definitely not normal times. It does impact all of us. What we call the immediate and the underlying determinants. So this is my nutrition hat on. We talk a lot about those determinants in the UNICEF framework when we talk about malnutrition, but we also can apply that to the people living with diabetes. Also, we've all been talking about this, about limited prioritization of NCDs and diabetes in humanitarian settings, and you can understand why, but we shouldn't continue with that. And I think this is really the conversation that y'all have been promoting. And this is why we need that shift for narrative that focuses on food insecurity across the lifespan, including disease-specific and, I would also dare to say, disease-sensitive interventions moving forward. And I think we all have been talking also about the need for those cost-effective, simplified models, be it are you a donor or you are a service provider or researcher. We all need that, as well as the patients and the people living with diabetes. So looking for frameworks, I'm an academician, and we love frameworks. And I really found it interesting that I couldn't find something quick and easy for me to point out that relationship between food insecurity and diabetes. I did find something from the US. Bear you, this is not humanitarian. And I know the slide is small, but we are happy to share that and the source. But what it's showing us here in this is that food insecurity is related to diabetes and obesity and other comorbidities in many ways that are really hard to kind of pinpoint into one direction. It's actually a cycle, which I'm going to try to do that on top of your head. I'm sorry, Caroline. But food insecurity is going to be impacting constrained dietary choices, and it's not necessarily in one direction. So sometimes we are in what we call a more food secure, more adequate times, others we're not. So what happens is you can have different compensatory strategies depending on if you're going through a fluctuation of the food security. Is it better? Is there open market? This is particularly in protracted conflicts, or is it complete food shortages? And what the people would do is either avoid eating certain food or avoid, wasting some food if this is the time when you're adequate, or they do overconsumption, which is very common in people who live with food insecurity. Is a time when you have food, you actually want to overindulge, and making sure your children do that. We've seen a lot of evidence on that with families trying to take care of their children and themselves, which basically leads to overnutrition. In the food shortages time, I think our colleague was just mentioning type 1 diabetes and type 2 diabetes patients in her work. Maisa was saying that parents and kids would skip meals. This is pretty common. These are like the first food coping mechanisms that we actually assess, but there's also other non-food coping mechanisms, of course, that I'm not going to talk about today. They do reduce caloric intake, and that actually causes a whole suite of changes, either hypoglycemia or hyperglycemia. Add to that stress, add to that all the others, so you end up into this other side of the spectrum here, where you end up also having impaired, in some cases, self-management capacities, basically your blood glucose monitoring capacity, the ability to make the right decisions for yourself. Add to that depression, mental health, and psychosocial well-being, or the lack of, exhaustion, fatigue, moving around, making sure you want to secure food for your family, let alone for yourself. There's a lot of competing demands. So basically, this is the cycle we're talking about. And Hilary Seligman and Schillinger have actually been looking at that more in the US based, but if it's in high-income countries, let's add to that exponentially in humanitarian crises. So I'm not going to basically go through the reading of those bullet points. I think I've covered it. As a nutritionist, I've always been proud to talk about how all those nutrition-sensitive and nutrition-specific interventions are important, and they really are very actively done in humanitarian settings. But one thing that I was really grappling with when I was invited for this talk is, and I've been talking about that in my classes and in some of my research, is why aren't we talking enough about NCDs in the mid of all these different frameworks that we've been working on? So this is, again, a busy slide, but I do want to say, be it where the old Lancet 2013 or the newer revisions of the Lancet, we were looking at what are the most effective interventions for maternal and child health. We always focus on the first 1,000 days. We'll continue to do that. There's a reason for this. Shelley was mentioning that if we do not limit low birth weight or we don't improve the status of, of malnutrition, reduce malnutrition, that's going to have long-term effects. That's going to continue to be a driving force. But in addition to this, not to compete with that agenda, but in addition to that, we need to think about frameworks that build into the existing platforms. Currently, we're working with the healthcare sector, so that's kind of like your left side under the nutrition-specific interventions, or even on the nutrition-sensitive side, we're working with the healthcare sector, but we also need to think about other non-healthcare sectors that are part of the conversation, especially when we're talking about food security and nutrition. It's food, people. We have to have a supply chain. We have to talk to the agricultural people. Food does not, it has its own challenges. We've been talking this morning about climate crises. It's affecting food availability. It also affects food access. And what I'm challenged with always, again, is that the interventions and the frameworks that we talk about really do not necessarily give the diabetes management or NCD in conflict-affected settings the time of the day. So one thing that Shelley has been making the point of, and I want to build on, is how we need to expand our definitions of what do we mean by vulnerable individuals. And even I know some people have issues with the terminology, myself included. Vulnerable may sound like a weakening kind of language. Let's put it, people who need to actually be given the voice to continue to share their thoughts. So that's the longer version. But what we currently use and what WFE uses is vulnerability assessment and mapping. Currently, the people who live with diabetes, whether you're a child or an adolescent or you are a mom, a gestational diabetes, or an adult, you do not necessarily fit that platform of vulnerability. In other words, you're not prioritized for interventions, and particularly food assistance programming. So that's going to be my next also thing, well, in the next other slide. Another thing when I was preparing for today's conversation with y'all is I was looking at some of the guidelines for diabetes management in humanitarian settings. This is pulled from a study that's focused on type 1 diabetes. What I did find is very interesting is that we don't even see the term food insecurity or nutrition, particularly within this platform. So there's room for us to also engage in this conversation, even when we're talking about diabetes on the short-term or long-term management, and particularly in humanitarian settings again. So again, I'm trying to make the case that food insecurity needs to be well-positioned in the conversation. I truly appreciate, Oria. I did not know when I put the slide that I was going to meet you in person. This is excellent work. Loved the fact that you also highlighted the blind spots of diabetes management and really building on the lived experiences of people living with type 1 diabetes, but also stakeholders and what they thought about it. It's the first time I hear the term insulin and food insecurity together, so I want to build on that. There's also other things that were highlighted from the qualitative research. This is a review of studies, but also there's other qualitative interviews that are worth looking into. They're all highlighting something in common, that we don't look at things in isolation. In other words, interventions should not be looking at things in isolation. When we're talking about insulin and food insecurity, there's a family that actually his life is disrupted. If I am a patient living with diabetes, which I'm not, so I will claim this, but I've worked with many, they actually would prioritize feeding their kids over taking medicine. They would do a lot of other coping mechanisms. So that brings the family relations, the financial pressure, the psychosocial burden. Do I take my medicine and not actually pay the bills? Do I lose electricity? What about the food? Will we be able to waste it or not? These are day-to-day conversations. So research is part of that. We're not sitting in ivory towers for sure. We're actually living with people, working with them. And part of the conversation that I think this work presented was knowledge translation, which we have so much room to work on. And other also aspects. So I'm gonna go faster through the rest of the slides to help also Anna with her task. So what are some of the research and evidence-based practice gaps and opportunities? Okay, every time I'm saying something, I'm not wanting to point a finger, I'm thinking that's a gap, that's a room for improvement. Currently, we've been talking about traditional food assistance modalities and even cash transfer programs that are very much focused, again, on the other forms of malnutrition, which is the undernutrition. Again, we're continue to be careful that we want to make sure that maternal and child nutrition is a key focus, but we cannot undermine the other forms of malnutrition we're seeing. And this is happening in overnutrition, NCDs, and also other micronutrient deficiencies. So I want to really make sure that we also tap into that. Some of the food assistance adaptations that we could consider moving forward and definitely need more research because this is really lacking is how we can complement vouchers for specific foods. In other words, complementing the traditional voucher systems or the cash transfers with other, what we call in the US community supported agriculture, farm to market, or access to basically directly the local farmers. We do that actually in Lebanon. Action Against Hunger has done a couple of jobs and good projects in Bekaa and in the south of Lebanon, where rural areas, you can actually give access to these families to have more fruits and vegetables. And in this market, you're actually providing livelihood for the farmers themselves. But that's not been studied well. So let's say that clearly. And also the other thing about being more diabetic sensitive or diabetes sensitive food baskets, that's something also we need to look into. Maybe even considering conditional food and cash packages that prioritize low glycemic options and more stable meal patterns. We also need to think about what type of interventions, dietary interventions, that need to be studied in terms of short-term and more longer-term impact. And this is where I talk a bit about unconditional and conditional cash. Some of you may be familiar with this, but I will be very brief. So Shelley talked about cash transfers in general. Think about it more like a financial incentive. Some of those financial incentives come kind of for free, in the sense it's unconditional. You get the money, you use it the way you want. You don't have to attend any sessions, you don't have to do any health education. The literature on the conditional and unconditional cash is very interesting. We're gonna speed through it in a minute. The conditional cash transfers are those where there is a condition tied to it, where basically you still have the ownership of the money. You just have to also, if it's more focused on malnutrition among under 5, you need to make sure that the mom, for example, is going and taking the kid and doing, or the parent caregiver, it doesn't have to only be the mom, but they have to do immunizations, or they have to do health screenings, or take specific health education. In the lingo of cash transfers, just to make things even more interesting, now we're talking about cash plus. Now I mean in the last 10 years. And there's a lot of interesting stuff coming out of this cash plus lingo, because it's saying that we're not going to condition it, we're gonna think synergy. I think it was you, Sirine, who said 1 + 1 is 3. Synergy. So that's what Sirine was saying yesterday. It's about whether cash with other integrated projects that are happening. It could be early childhood development, it could be nutrition-sensitive agricultural projects, how those together can influence specific outcomes. So what's the evidence on that? Overall, cash transfers have been found to be like the unicorn of food assistance programs. It's very positive, but I want to caveat and say this is not necessarily always applicable to NCDs. In fact, there's only one study coming from the Johns Hopkins team that actually was done in Jordan, and they did look specifically on glucose monitoring and other health outcomes, and they found that the combining of conditional cash, so cash with health education, showed to be effective in improving expenditures, health service utilization, medication adherence, blood pressure, and diabetes control among Syrian refugees in Jordan. Also, what they found is that the health education alone group were also seeing effects, although a little less. What's interesting, in my opinion, is that the cash only, or the multi-purpose cash assistance, did not see effects. In other words, just giving cash without providing some kind of behavioral change communication strategies or other health education did not really help. This is the study we need to expand on. These are the kind of research we need to do more of. Also, there's few studies reporting potential negative or unintentional effects of cash transfer programs. That's not NCD specific, that's just general on nutrition. And these are interesting because if you take a look on the right side, so this is from a really really well done mixed method systematic review, they found all the quantitative results. So what I showed to you on the, what is this, the right side? My brain is kind of confused on this. On the left side of your screen. On the right side here is this qualitative research looking at cash transfer modalities and health outcomes. There are not many. There's only 5 that you can see here. And what's interesting here is you find some mixed evidence. In other words, there's some places where cash transfers need to be looked at with a little bit of an interesting angle. It could cause more depression among women. it actually did cause some financial security issues. That's particularly coming from Afghanistan and Cameroon study by Fresero et al. And in Palestine, Abu Hamad also found some also interesting results in terms of social stigma. So also things to study further. We do need to do more comparative research, in my opinion, and in many of the authors and reviewers. We need to look into that cash transfers versus, conditional versus unconditional, cash plus in this mix on specific diabetes and NCD-related outcomes. I've talked about how positive the cash transfer modality has been, but when it comes to cost effectiveness and NCD, I think this is where we need to spend a little bit more of our money and time on, because if we can show positive effects and healthcare cost savings, that can be really good from a donor perspective. I'm looking at you, my colleague from the morning. Other research gaps we've been talking about, and I think I can expand on too many slides, but I really have to keep it short and sweet until now. Patient-centered research, barriers, stigma, psychosocial needs, definitely warranted. More qualitative work is definitely needed. But I think I'm more of an advocate of mixed methods. So whenever we're doing RCTs, to think about mixed method. If we're doing quasi-experimental, also qualitative, formative research, the one that Omar, our colleague from IRC presented was excellent, or IRS. Sorry, International Rescue, I have to always think about the abbreviations. Studies on community engagement strategies, basically the conversation we've been having about meaningful engagement earlier. This is important to look into how, by building the trust and the cooperation with the local populations, we can really make the interventions ready to be mobilized even before the crisis happens. You've got your network, you've got that is the team, that's the committee, that's the entity that you need to work with. Psychosocial stress and stigma and low health literacy reduce engagement with self-management based on the studies. So we need to think about how also when we're doing diabetes prevention or management, how we can also integrate the psychosocial mental health support into this. And I totally believe in what other colleagues have been mentioning yesterday and today about the targeted family and community-based interventions. It's not just about providing food baskets or cash transfers. It's about how the family can also be an active agent in that journey. And one thing that we are using more terminology in high-income countries, I think it's very relevant for LMICs, but also humanitarian settings, is this diabetes distress concept, which is basically bringing the stress of an exhaustion of working with diabetes and having to manage it day in and day out, thinking about how many injections you have to keep, what food and carbohydrate counting. It can be exhausting for the best of us. But there's also some challenges with research in humanitarian settings that I know many of you can actually speak volumes to, and I'm looking forward for the Q&A. How do we balance practicality with rigor? I think this is something we have to always continue to look forward in terms of our conversation. I don't think RCT is the only solution. I think RCT is the gold standard, but we have to think about shifting in the research mindset between matching our aspirations with practicality. Having those research collaborations between academia, implementing agencies, and the community members and people living with diabetes and other NCDs is needed at the inception of the projects. I've been hearing and talking more about co-production and co-creation of research studies. It's not enough to talk about the dissemination piece and say, how does that look for you? It's actually insulting, if anything. I did not design a study, not even engaging your voice, and then I'm gonna come and tell you, what do you think about the dissemination? So I think really, really very important is whether we're designing the right questions and designing the right methods for that context. It can be difficult, but if you've created that system and that trust, you can build on it. So that's the other point I was talking about. And really balancing this conventional level of research evidence where our donors, with all due respect, love RCTs, love clinical trials. It is so tough to think of this as in humanitarian settings because it's not sustainable. And in fact, it's very clinical in its approach. It's not necessarily community driven. So things to keep in mind, and I am told I have to conclude, so I am done, I promise.
Thank you. That's given us a lot to think about and digest, and hopefully some of that is also being captured in the research prioritization from this morning. So last but not least, of course, Caroline, over to you to talk to us a bit about policy. And we're actually done with our slides, so we can just look at Caroline instead of the screen.
Don't look too closely, but yeah, thank you very much. Yeah, I don't have any slides, so it's just a few comments and a few remarks, really, some thoughts and a little bit of suggestions for action and how we can take things on in the future. So firstly, I would also like to thank IADA for inviting me. I really do feel honored and privileged to be here, but especially on this panel. And there are several of us in this room at the moment that have been thinking about the question of nutrition and NCDs, or nutrition and diabetes in particular. And we've had several tentatives, several forays into what can we do better, several meetings in an interagency level. But I mean, I think we have to recognize we haven't got that far. So I see this panel today as really a kickoff of something that's super important, and it's day one of the future, hopefully, for a better meeting of minds of nutrition and diabetes, with that that person-centered focus on how we can collectively improve lives of people living with diabetes. All that's being said, I've been asked to explore the sort of the intersection of diabetes, NCDs, and nutrition from a policy point of view. And when I first got the brief, I thought that, you know, that's fine. And then very quickly I looked and I was like, well, the intersection's a bit invisible, isn't it? There isn't much. I didn't look on the other side, so I thought it was very interesting that when you look at the frameworks and policy of diabetes, there's not much nutrition in it. But it's exactly what we're seeing on the other side, that the nutrition and food security policies don't have NCDs and diabetes in it. So we have a problem, Houston, I think. We really need to bring that together, but I'll explore that in a minute. So a lot of this has been said, but our humanitarian nutrition and food security policies and frameworks, sort of overarching frameworks in general, really focus in the majority on acute malnutrition and micronutrient deficiencies. And sure, they're urgent, they're life-threatening conditions, and should be prioritized in one way in the humanitarian action. But diabetes is not. And if we look at food assistance, for me, I'm just going to look at two sort of separate. You mentioned it. One on the food security, but really coming from the food assistance angle, and the other that's much more sort of patient-focused and nutrition education, that the two really go together, but one from the food security and more from the nutrition side, as examples of what I've been looking at. So the food assistance, really, it's designed for the majority in a population. It's designed to be rapid. It's a public health approach. It's for the majority. It's about survival. It's about scale. It's about efficiency, and it's not really about individuals. It's about the masses. And the targeting is very limited. I mean, you mentioned it, and I thought your list was quite long, because in reality, in my experience, it really is children and pregnant breastfeeding women. Yeah, there is mention in the policies and the framework, but actually in reality, when you're on the ground, when you're at the coalface, it's children, and then, if we've got the resources, pregnant breastfeeding women as well. I mean, what is encouraging is that we are starting to see NCDs in policies, and I think it's fantastic. I was really happy to hear these examples today from MSF, from IRC, and also hearing about some of the work that UNRWA's been doing as well, specifically on that. But it remains fairly rare. And like I said, people living with diabetes are rarely, if ever, considered in food assistance design. And in fact, in my experience, so I know I don't look it, but I've got over 30 years of experience in this field. And one example of, on a population level, an intentional tailoring of a food basket for people living with diabetes. And that was not in an acute emergency, it was in a protracted emergency in amongst the Sahrawi refugees in Algeria. But it does give us hope. It's one experience, 3 decades, pause for thought on that. But there's hope, right? And there's hope, and now there's all of these other sort of newer. So we've been over the why it's unsuitable. I won't go over that again because I think my colleagues have adequately demonstrated why a carbohydrate-rich food basket and an environment, a food environment where fresh, diversified foods, vegetables, dairy, lean protein are either unavailable or unaffordable, and so inaccessible to individuals or families living with diabetes. Even when counseling, so if we leave the frame of food assistance, when counseling is offered, it really falls short because it's just not practical. It's not practical for the people that are, I hesitate to say receiving the information, but are participating in the groups of nutrition education. And it's not practical because it's just not, oh, already, okay. It's not, it's just impossible to implement when all you're getting is this, and what's available in the market is that, and it's far too expensive for you to get anyway. So what can we do? I've got 1 minute to say what we can do. I think I might take 2. So visibility really enables our action here, and data is really missing. So there's nothing in the policies, but actually there's nothing in our nutrition data either. In terms of, we're looking at how many, what are people's needs? I mean, really the lived experience, what are people's needs? To be able to describe and properly document how current systems are failing people living with diabetes, we haven't got that data. And without data, we have no visibility, and without visibility, we have no possibility of prioritizing this in either direction, I would say. We have indicators that are entirely missing in any of our frameworks. There are no indicators on NCDs or diabetes in particular in our frameworks or our sort of standard emergency assessments. Now to come on to I've got 4 points. So what can we do here? Well, I think, I mean, some of it has been said, so it's kind of rounding off some of this, but we need to include it in policy. But to be able to do that, we need the data piece. So for me, the data piece is overarching. Once we've got that, we can include it into policies. We do need to strengthen sector coordination, which again is fairly weak and is very siloed. We have this very siloed approach that remains despite all of the best efforts of clusterization and coordination mechanisms in emergencies. But we also need this context-specific messaging, and Omar, I think, displayed that very well. Why that needs to be contextualized. But we also need flexible modalities. So to pursue the cash plus SBBC and really look at not only having a minimum expenditure for cash, but really a nutrition focus on the cash value of the transfer that's being given, and with a specific targeting there for people living with diabetes. And again, this practical guidance that you're all working on so well, I think it's fantastic to see these examples. and let's see more of it, but something that's easy to adapt, and also in a range of contexts and a range of literacy levels as well across the humanitarian emergencies we see. So it's not about creating parallel systems. That really rarely works in emergencies, but it's about integrating diabetes into the systems we already have and do it better and work together much better. Because emergencies, they don't level the playing field, they just exacerbate every single problem that anyone has in their normal lives. And this is one of it, and we have to do better. We have to do better together on the nutrition and food security front for people living with diabetes. So thank you very much.
Thank you, Caroline. That's wonderful. So I know that we have been talking a lot up here, so we're going to do things a little different, just thinking about time. I actually want to give the audience the opportunity to pose some questions to us first, and then if there's still time or you don't have burning questions, we have some other areas to discuss. Yes, go ahead.
Yeah, thank you. Kiran Jobanputra, WHO and IADA. Thank you for this panel. I think this was a great, as you say, a start to something that we've wanted to start discussing for a very long time. I want to it's really to echo the last point that Caroline made, because the importance of data on this. So this year in May, we brought out a policy brief, WHO policy brief on strengthening integration of NCDs in all hazards, preparedness and response. It's available on the website. We didn't feel able to say anything on this topic because we had no data to refer to. And this policy brief was underpinned by analysis of 30 recent emergency responses with 8 in-depth country case studies, and there was nothing on this topic. So I would just echo that call that, across any organizations that are able to document, pilot, work on this, to share it, to publish it, because that policy brief can be updated, and it's a shame that we haven't been able to say anything on this so far.
I just wanted to read a question that came in from online, thanks to James Elliott, one of his friends from Dadaab, Gabriel. I'm just going to read this question. It's a little bit long, but I think it's very appropriate for this time that we're currently in. He says, after the USAID cut down, the UNHCR WFP started the DA program, Differentiated Assistance Program. This is where the food supply has been classified to 4 groups. Group 1, prioritized for food supply. Group 4, no food supply at all. Unlike before, where everything got shares based on family composition. So a family got 4 shares for the 4, and a family of 2 got 2 shares, basically. With the new program, some families have been stopped from supply, i.e. selected under Group 4. Hence, some persons with lived experience are currently struggling to access diabetic-friendly diet, as they have to consider the whole family, unlike before, where at least the other family members were helped by the WFP UNHCR, reducing the finances need to sought for food for lived experience persons. So his question is there a way IATA can initiate a research program on the impact of the new DA program on glucose management, and B, have a recommendation on ensuring families with a lived experience person allowed to be categorized as a family in need, hence continue food supply from WFP? It's a long question, but I thought it was an important one to mention.
Maybe we'll take one more if there's one more from the audience.
Thank you very much. Actually, it's very, very important and attractive topic that I personally and together with the team, we try to push this nutrition, especially in our context where the nutrition is not part of the clinic and not part of the management of diabetes patients. It's unfortunate. And I think going to the topic that with all this cut and all these crises regarding foods, I think the thinking towards the livelihood and what things could be done as a DRR, as a preparation in advance, could be an important thing. And going back to the Arab cultures where we did a lot of food preservation before and making all this ready for the nutrition of the whole family, I think these ideas could be worked on perfectly. The last thing that I wanted to bring is that I'm a bit sensitive to the word diabetic nutrition or diabetic food, because I think it's opposite. This is like the healthy food that all the family should adopt and should work on, and rather than cooking two cooks in the family, and this is for the diabetes and this is for the healthy. I think it should be like the opposite. Thank you.
I think, why don't we take one, I saw hands jumping up. Yeah, why don't we take one more and then we'll respond. You haven't.
Sorry, it was a little bit more of a quick comment. I hope that's okay. But my name's Aurea James. I'm with the WHO Global Diabetes Compact. And Lamis, I thank you for showcasing the research that I've done. It's the first time I've seen it outside my own personal laptop screen. I did my master's thesis on diabetes in humanitarian settings, specifically from a qualitative lens. And the biggest theme that emerged across everything that we did, and I had a wonderful team of co-authors, was this intimate relationship between food insecurity and insulin insecurity in a way that they could not be divorced. They were related and so deeply connected to one another that I grouped them up into a theme of food and insulin security, which you showcased. And perhaps I do have a question, and it's, do you have any recommendations or thoughts about how to better bring food into all the ongoing conversations about insulin? Because as you know, insulin gets a fair amount of political attention, at least from an advocacy and visibility lens. And how can we ensure that food security and nutrition is tied into that conversation, not as an add-on, but even as a pillar that is central to kind of the experience of using insulin?
No, thanks. I just wanted to add a small point on the Dadaab one. I think this question came from one of our team members. Actually, I'm super happy that he's advocating for the people we're working with there. MSF Switzerland has been there for many years, and we have at the moment about 100 people using insulin, most of whom have type 1 diabetes, and we have many hundred with type 2. And last year, so they're very anxious about this change that's coming with the WFP food assistance, but they've been anxious about the food security situation for people with diabetes for many years. And often when we have case discussions, actually it revolves around challenges for patients related to food. Last year, the team developed an advocacy document outlining these challenges and calling for two things. One is specifically considering people with type 1 diabetes as a vulnerable population for food assistance. And the second is considering more adapted food in general for people with diabetes and other NCDs. And this was a document for WFP and UNHCR. This was a field initiative to really see how they could advocate, and received no response to that, and it went absolutely nowhere. So I just wanted to add that background as well, because this is a very important topic for the team in Dadaab that is actually very representative of many of the places we work.
Thanks for that context. So I'm going to ask the panelists if you can keep your remarks down to 2 minutes or less, because I know we're short on time. So I was thinking, maybe Omar, are you still with us? There was a point that was raised initially on not having any data to feed into the NCD policy that was just put out by WHO. And I guess my question to you, or if you can respond to the plans for sharing some of the research and results that you all are generating from Somalia.
Yeah, okay. Thank you, Ashley. Shelly, actually. It is actually for the research in terms of the NCDs general is very limited, specifically in the humanitarian setting. And there was some surveys and assessment we did in the last 2 to 3 years. And one of these studies and assessment is actually come out that we actually consider on looking for uh, the dietary guide that is actually mainly currently is one of the gaps being identified based on the assessment is the studies we did the last 2 to 3 years, and also another aspect was about the food insecurity that the diabetes patient are also facing on that, and that is why actually we have been reviewing some of the data and the research that has been done in similar contexts for Somalia. And I'm happy to say that we are currently actually, after this formative work, we are looking for to develop and also test and document for some of the interventions, which are mainly for, as I mentioned, the contextualized nutrition guide for people living with diabetes. And also that will be a very simplified, locally tailored diet guide for people with diabetes and hypertension. And it will actually provide on practical dietary advice, whether it is at the facility, at the community level. And also we are expecting this to inform the Somali National Nutrition Strategy that is ending on 2025. We will be working this with the MOH, the Minister of Health, and the rest of the stakeholders. And also, as I mentioned, we are looking for integrating the NCD and the nutrition pilot with the cash support. And I think this is also something we are going to develop and test and also document. And I hopefully maybe September next year we will be having some feedback on these two key areas. Over.
Great. Thanks, Omar. So some research coming out that'll feed into the global discussion. There were a few questions raised on how to kind of bring food into the picture, and talking about insulin insecurity and food insecurity. I'm wondering if you'd want to
Yes.
talk a little bit about
I just want to mention, as my colleagues mentioned, the importance of nutrition education and to use the funds into courses of nutrition so that we can see what the patient need, and we can understand the cope of mechanism, and we can apply this mechanism into the life of the patients to help them stabilize their blood glucose and live a good, healthy lifestyle. Regarding the nutrition and food security, as Aurea mentioned, they cannot die forced, because if the food is limited and is insecure and the patient cannot have access to food, so at the end they will not have a good nutrition and a healthy nutrition. So as much as we can as a staff and as organizations, we focus more on the food assistance and to like design tools and maybe posters or something can help the patients to have good nutrition and the importance of food security. Thanks.
Thank you. And then there was a lot on potential research that we could be doing, evidence generation. Do you want to comment a bit on that?
So excellent questions. I think the federal cuts that are happening in the U.S. are showing us some interesting changes. The global funding cuts, USAID dismantling, is also showing a lot of effects, and people are improvising, and those organizations, WFP and others, are basically trying different modalities. I think the quick answer to the question is yes, we need to look at the impact, and we need to do that rather faster than, because if we're reducing the rations, and we already know that even with the current modalities, the survival minimum expenditure basket, the SMEB, or the minimum expenditure basket are minimum. They're really kind of like the floor, not the ceiling. So if now we're cutting that even lower, we're asking families basically to cope by cutting even more their food, or making those harder decisions, which we've talked quite extensively about. So the quick answer is we do need to look into those. And my hunch is that the outcomes will not be very positive, and maybe this is exactly where we need to guide things forward. I do want to just, it's not a research specific question, but I think this was brought up from my colleagues from Palestine, but also examples from Lebanon. I agree that we cannot keep siloing also that there's specific dietary guidelines for people with diabetes separate from hypertension. This is a very clinical approach. We can have specific guidance under the bigger umbrella, which is guidelines at a national level. And I think one of the conversations we're having, I know WHO is very active, and FAO, on helping countries develop their own guidelines. I think most of the people don't know about them. We've participated in development of guidelines in Lebanon. We have a beautiful food-based CEDAR guidelines that most of the kids don't even know about it in schools. We've done it for children, adults. The healthy eating options should be for all, not necessarily for only people living with NCDs. In fact, we can make a case that NCDs are happening to a large extent, particularly type 2, because of inadequate access to healthy food. So, and I think this was brought up earlier in terms of promoting healthier food environments to ensure that people, it's not an individual also choice. It's not that you don't know. It's like you know, but you can't eat it because it's not in your environment. So one of the things that I think we need to look into is how tax subsidies, which you're like going to be like, Lamis, what are we talking about? Tax subsidies might be one of the things that's going to help all, actually individuals, particularly cutting down on sugar, sweet, and beverages consumption, which is one of the ultra-processed food that should be limited, and that's highly consumed among families and children with food insecurity. These are larger things. We're talking policy level. Let's talk food subsidies. Cash transfers is one targeted approach. I agree with you, Caroline. We need to think about the other complementary interventions that are policy related. It's about subsidizing fruits and vegetables so everybody in the family can afford it. It's this complementarity that's hard to kind of make the case for today, given the funding cuts, but it is necessary. It's really kind of about cost effectiveness. If we don't do it now, we're going to end up spending more money on treatment of NCDs than on prevention.
Thank you. I think then the last word to you, Caroline. I'm interested, if it's not about the funding cuts, I'm interested if you can talk a little bit about advocacy. Philippa mentioned how there was a brief that was sent to World Food Program and there was no response, but thinking a little bit forward as to how do we advocate for nutrition and food security, how do we move forward with some of the potential policy change?
Well, I think I'll repeat myself, but I think data is at the base of all of that. But coordination and working together. I mean, in that particular Dadaab situation, I also lived through it, not as a lived experience, but I was working in the camps in Chad when the same policy was applied in Chad, the four level, with some people getting everything and one group getting nothing, and it truly was a difficult time for people. So for me, we were talking a lot yesterday about the political brief, or the political document really being that floor and not the ceiling. I think if we are able to collectively push together, and that also means, to be fair, bringing WFP on board in this forum as well, is to open a trapdoor to that floor that you're creating with a political document as well, and open the door to synergies between the two worlds. Like we saw, there's no nutrition in the diabetes documents, there's no diabetes in the nutrition documents. And I think there is an opportunity at the moment to open this trapdoor in both of our floors, and to aim a little bit higher on the data rail, let's say, by the next funding cycles.
I think that's a good way to end. So thank you, really appreciate it, and really excited to see what direction this discussion will go in, and thank you for having us all.
Thank you so much. It's a huge topic, lots of work to be done, and thank you. And I will just say we tried our very, very best to get WFP here next year, hopefully. We're going to have lunch now, and then we're going to reconvene here at 1:30 briefly before we break into our sessions. So just come back here after lunch.